So maybe some closing thoughts as to, we spoke about so many different topics here that get us excited, but pick one of your favorites as to the next couple of years. What do you want to see on the horizon? What's going to make an impact in your view?
Well, I'm looking forward to continued advancement with targeted therapy. Yeah. We have a lot, but I think there's still a lot of mutations out there that don't have treatment. And I hope we get to a day where every mutation has its targeted treatment and our patients do much better. And then the other area for me, particularly in the diagnosis and staging, is the role of blood-based markers, and how do we incorporate high-performing tests as we validate them into the risk stratification of our patients with lung nodules, into maybe surveillance after treatment. And so, those blood-based markers are still in my mind, in evolution. Mm-hmm. They're trying to find their way. They're trying to get better. There is a future for them, but I'm looking forward to the next 5-10 years and how those are going to evolve and help us take care of these patients.
Great. Jay, what gets you most excited about the early stage lung cancer landscape evolving or elsewhere?
Yeah, so I think two issues. One, we've talked so much about neoadjuvant chemo IO, but I do want to say that there are times where it's more appropriate to take that patient first to surgery. I think of neoadjuvant chemo IO as a medical oncologist thinks about first-line therapy. If you have driver mutations where you would not pick chemo IO as your first-line therapy in the metastatic setting, I don't think that patient should necessarily get neoadjuvant chemo IO, because you wouldn't do that in metastatic disease. So why would we do it in earlier stage? Because waiting 3-4 cycles, that patient may progress. So to me, there are patients driven by the molecular profile where I'm going to say, I'm going to take that patient to surgery, or preferably put them into a trial. So I want to make that distinction that not everyone should get neoadjuvant chemo IO. And secondly, if I think that they have poor immune biomarkers to predict that they're going to have a response, and it's going to determine whether I do a lobectomy or a sleeve lobectomy versus a pneumonectomy, let's say, I'm going to take that patient to upfront surgery because I don't want to miss my opportunity to do that sleeve resection and end up with a pneumonectomy had I waited. And these are maybe the patients that are PD-L1 negative, wherever we fall into TMB and your view on TMB being low, and then maybe they have a KEAP1 or STK11 where that they're unlikely to respond. And these types of patients should go to surgery first. The thing I am interested about also are not only the new strategies coming out, but I agree with the targeted therapies. I think more and more targeted therapies are going to come into the early stage setting. They're predominantly in the adjuvant trials because the NGS testing, particularly globally, is just, it's not practical right now to check up front. In the US, we're doing more and more of that, but that's not a reality right now globally. So much of the trial developments are in the adjuvant setting. But we do need to move it up, and I think the expectations should be a little different. I mean, we're not going to achieve PCRs, and we need to lower our threshold that, one, we don't know what path regression means with targeted therapies, but secondly, I think PCR may be too high of a benchmark. So you're looking at MPR at minimum, and then what does it mean? We still need to correlate it with survival, and the difficulty here is going to be when everyone's getting that targeted therapy, like in Neodora, why do we expect that 9 weeks of upfront OC or any other targeted therapy is going to necessarily impact long-term survival when everyone's getting standard of care targeted therapy? So then what is the point of doing neoadjuvant targeted therapy? Well, it's to move it up. It's to give your best systemic therapy as soon as possible, because like when you look at the Adora trial design, it takes 5 months for that patient to get the osimertinib started if you're giving chemo in the adjuvant setting. So it's to give your best systemic therapy agent up front as early as possible, and I think that is the value. And then the path regression data, without knowing the resistance mechanisms, the path regression data will immediately delineate who are most responsive and who are not. And I think it allows us to say, should that patient get 3? Now we're talking about 5 years or indefinite of OC, or let's say another targeted therapy agent. Should we escalate in that non-MPR group? Should we do something different. So, I mean, I think that's going to be the value of neoadjuvant targeted therapies.
A great comment, and again, so much excitement building up because the NeoAdora study results will be presented in 2 days, and I'm sure we'll be adjusting our practices as a result. But last word, Mary, our newly elected ISLAC, board member. What keeps you awake at night?
Good things actually, because we've been so excited about all the wonderful research in lung cancer. But I think personalized medicine is really going to be where it is in the future. I'm excited about screening. There's a lot happening in the screening fields. I know we're not there yet, but we are really kind of pushing forward with that. We're learning how to get patients in the door, get patients staying there, and that is really improving survival. We have switched from a lot of our patients coming in at stage 4 because of our screening program. We're now coming in more at stage 1 and stage 2. It's flipped from stage 4 to earlier stage. So that is really exciting. And we haven't talked about AI at all, but I think AI might be pivotal in the future. There's a lot that is happening in that space, so
maybe
I'm excited about that too.
We look forward to coming back next year and learning about AI and lung cancer screening. So with that, we just had a fantastic panel conversation. Thank you so much, all of you. And thank you for listening in. Lung Cancer's Roundtable, multidisciplinary discussions. These were our closing thoughts. Thank you.
Thank you.
Thank you.